We are dealing with some of the most important fractures that you should know in all of the musculoskeletal system. Uh, a basic physician should be able to, diagnose well of these particular fractures. Okay, and a detailed description of all these fractures has been given down in the practical slides as well. Okay, the mechanism of injury and all other things is actually given down in the practical slides. So make sure that you read this particular practical slides in detail so that it will be helpful for you later on when you are actually trying to learn about the orthopedics as well. Okay, most of these things forms the basis from the radiology itself, and there are a lot of things to learn, particularly for the people in India, since you guys are actually going to give the FMG exam. Orthopedics actually forms up a lot of questions when it comes down to the fractures, metabolic bone disorders, tumors of the bones. Okay, it forms a lot of theory, and so many questions are likely to come from these chapters. Okay, a lot of case scenarios. So make sure that you learn this chapter well. Okay, the first fracture we are going to look at is the Colles fracture. Okay, Colles fracture is a very famous fracture which is commonly seen in elderly females. Okay, where Colles fracture is the fracture defined as the fracture of the distal end of the radius with dorsal angulation. Okay, distal radius fracture, okay, with dorsal angulation is actually called as the Colles fracture, where the mechanism of injury is caused by a fall on outstretched hand, which is also known as fush. Okay, fall on outstretched hand is called as fush. Okay, and it is also associated with the fracture of the ulnar styloid process. So how can you define the Colles fracture? Colles fracture is the fracture of the distal end of the radius with dorsal angulation associated with the fracture of the ulnar styloid process. Okay, so that is Colles fracture. You see here, there is a stepping of the cortex here, and there is a stepping of the cortex along the distal end of the radius. Okay, this is the right hand we are looking at. Okay, there is a fracture of the distal end of the radius, and the styloid process of the ulna is fractured. So this is a classical Colles fracture, as simple as that. Okay, it will be happening when you actually fall on an outstretched hand, and Colles fracture is generally seen in elderly females. Okay, so this might be happening because when an elderly female is actually trying to prevent a fall, and she's trying to prevent a fall when she is actually trying to extend her hand and trying to fall on that one. So that is how a Colles fracture actually happens, right? So this Colles fracture is also known as another condition which is also called as the dinner fork deformity. Okay, that's what you have to remember, at least for now. Okay, Colles fracture is also known as the dinner forks deformity. Okay, it is there present there in your practical slides. Okay, you have to give it a read later on, but you have to understand one thing, that the Colles fracture is the fracture of the distal end of the radius along with the ulnar styloid process, and the mechanism of injury is by Fuchs. Okay, right? That's it, as simple as that. Then there is another fracture that is actually known as the Smith's fracture. Smith's fracture is also called as the distal radius fracture with the palmar angulation. Okay, distal fracture along with the palmar angulation. Uh, so that is actually Colles fracture and the Smith's fracture. Look at that one, the image I sent you. Okay, you see here, the Smith's fracture is also known as the reverse Colles fracture. Okay, it is actually caused by a fall on the back of the flexed hand. Okay, so where that one will be the extended hand, with this one will be a flexed hand. So in the picture I sent you in the group is a fracture. A is the Cullis fracture, where there will be the distal end of the radius that has been fractured while falling on an outstretched hand. Well, on the B side, you will actually see that there is a fracture again on the distal end of the radius as well, but there will be an dorsal displacement. Okay, so dorsal displacement is actually the Cullis fracture, where the palmar displacement is actually called as the Smith's fracture. So Cullis fracture and Smith's fracture are entirely different. You can technically say that the Smith's fracture is also called as the reverse Cullis fracture. Okay, so that is what you have to remember here. Okay, uh, Cullis fracture is the fracture of the distal end of the radius along with ulnar styloid process, then on and falling on an outstretched hand. But Smith's fracture is the palmar angulation, okay, falling on outstretched hand with the palmar angulation, where the fracture of the distal end of the radius is present. So that's what it is. And Cullis fracture will have dinner fork deformity. That is what actually you should try to remember by the end of when you are learning about the fractures of the upper limb. Then Zone's fracture is the transverse fracture of the fifth metatarsal. Okay, remember Jones fracture is the fracture of the fifth metatarsal about 1 to 2 centimeters from its base, caused by the plantar flexion of the foot and inversion of the ankle. Okay, when you actually have the plantar flexion of the foot, I think you know what exactly is a plantar flexion, and then the inversion of the ankle happens. So such kind of fracture is actually causing the fifth metatarsal fracture along 1 to 2 centimeters from its base. So this is actually called as a Jones fracture. Then we have a special fracture that is actually called as the boxer's fracture, which is happening with the fifth metacarpal, okay, with the palmar angulation and the distal fracture fragment. Okay, so this one, fourth metacarpal, may also be sometimes involved. So it is actually happening when you are trying to punch a person or a wall. So this is actually called as the boxer's fracture. So let's try to see some pictures here. You see here in the Cullis fracture on the lateral side, you see here there is a dorsal displacement. Okay, dorsal angulation, which actually makes the hand look like a fork. Okay, so that is why we call it as a dinner fork deformity. But when we compared it to it, this is actually not looking like a dinner fork, but it is the hand is actually completely bent towards the palmar side. Okay, this is the palmar side, this is the volar aspect. Okay, palmar side and the volar aspect. So in dinner fork deformity, the hand is a Cullis fracture, the hand is angulated towards the volar aspect, dorsal side. But in Smith's fracture, this is coming down towards the palmar side. So that's the reason we call it as the reverse Cullis fracture. And the fracture is present along the distal end of the radius, where there will be an angulation deformity as well. So that is the Smith's fracture. Is it simple? Understand? Yes? Okay. And you see here, zones fracture, like I said, it is actually happening along the base of the fifth metatarsal. And you see here, when there is a plantar flexion of the ankle joint, you see here there is a fracture line, radiolucent fracture line, that is present along the base of the proximal base of the fifth metatarsal. So this is a zones fracture, and there is an avulsion fracture of the apophysis as well. Okay, which is actually the avulsion of the tuberosity, tarsal tuberosity as well. So that is quite simple. So that is how you're actually going to recognize, right? So this is a zones fracture, right? And then this is a boxer fracture. You see here there is the fifth metacarpal that has been involved, and there is a fracture line that is present along the distal base, right? So this is the boxer's fracture. Just you have to recognize from the pictures. So this is a picture of a Smith's fracture, where the distal end of the radius has been fractured with a palmar angulation. Fifth metatarsal with an avulsion fracture of the tibial with the tuberosity, okay, tarsal tuberosity. so is actually called as the uh, Zone's fracture. The fracture of the fifth metacarpal is actually called as the Boxer's fracture. Very, very simple. It's not really very difficult to understand. They are quite easy to recognize. Okay. Then we have the March fracture, which is also known as the stress fracture, where the shafts of the second and third metatarsals are the one that are being affected. And it is actually happening because of the repeated microfractures from the foot from trauma, such as marching. Okay, heavy marching, heavy panting of the foot on the ground actually causes the stress microfractures along the second and third metatarsal, so which is also called as the March fracture, right? Then the other thing, very, very important fractures that you have to remember are two in nature. Okay, they are the supracondylar fractures of the distal humerus in the children. Distal humerus is the far end of the humerus. Okay, these are very, very important fractures that you should learn, and it is because it is very, very common in child, because a child is likely to fall down on their elbow. Okay, and they actually will cause the posterior displacement of the humerus. Okay, the posterior displacement of the humerus along the olecranon process of the uh, radius and the ulna, and then the olecranon fossa, which is actually articulating with them, will be actually displaced. So supracondylar fracture is the happening between the medial epicondyle and the lateral epicondyle, where the olecranon fossa is present in the between. So that segment will be displaced. So that is actually called as a supracondylar fracture. And they are more evaluated down in the lateral films only. Okay, so you have to remember the best orientation of a supracondylar fracture is done on a lateral film. Okay, and you should actually understand that the ossification centers of the capitellum will be actually fractured here, where there is a humeral fracture line that is present down along the middle third of the ossification center of the capitellum. So that is where the fracture line is present. So this line actually passes anterior to its normal location. When you actually look at the picture, you can actually understand. You see here, this is the supracondylar fracture of the humerus, where you can actually see this is the capitellum. So this one is actually the fracture, which actually will be posteriorly displaced. And at the same point of time, you will be seeing here a sign that is actually called as the sail sign. Okay, which is actually called as the sail sign. Okay, and this kind of view is this is the lateral view, but the best way to understand this one is actually called as the coils view. Okay, remember the names. You have to just remember the names here. There is nothing to understand. Okay, okay, sail sign, which it is there in your practical slides in detail so that you can actually understand. But you understand here one thing, remember one thing, that the sail sign is a fracture, is a feature of supracondylar fracture with posterior displacement. Simple, right? Okay, that's it. So you have to understand that they actually form up a straight line when the elbow actually forms to form a straight line. But if there is an angulation that will be lost along this place, actually this line has to enter from the midline of the shaft of the humerus, but it has been moved anteriorly towards the anterior edge of the humerus. You see here, this straight line has to be, when in correct position of the elbow, this line has to pass from the mid shaft of the humerus. But you see here, that line has moved anteriorly, which means to say the humerus has moved posteriorly. Did you understand this? Yes? If I draw a line, the normal orientation, the straight line should be present from the middle of the shaft of the humerus to the olecranon process. But if that one did not actually happen, so the line actually moved anteriorly, so there is a posterior displacement of the humerus. And I can see there is a lot of hypodensity that is present along the elbow joint, which actually say that there is a lot of joint effusion. So such thing is actually called as the fat pad sign, okay, which is actually called as the anterior fat pad sign. Okay, anterior fat pad sign is seen in supracondylar fracture. And at the same point of time, in these fractures, there can be a radial nerve injury as well, because the radial nerve is actually passing through this one. So that's the reason there can be a radial injury nerve as well. Okay, radial nerve injury can also happen in supracondylar fractures. That is what you should remember here. Okay, next, the most important thing we are talking about, the last part here, is the hip fractures. Okay, hip fractures, when we are trying to look at the cortex or the zones of the increased density, actually suggests that there is an impaction. Remember, hip fractures are the common in more older adults, okay, especially females. It can be happening as a secondary condition related down to osteoporosis, and where there will be impaction driving of one bone part into another fracture segment is actually called as an impaction, which is commonly seen in hip joint, okay, head of the femoris fracture. You see here, this is the acetabulum, and this is the femoral head that is present inside the acetabulum, and we can see that there is a compression of the femoral neck because of the impaction or driving down the femoral neck into the fracture. So that is actually called as the impacted subcapital hip fracture. Okay, so it is quite simple. The fractures are quite easy. You can actually say that this is the fracture of the neck of the humerus. Okay, this is not the fracture of the head, not the fracture of the acetabulum, but this is the fracture of the neck that is completely impacted down into the fractural femoral head. So simple. So this is the impacted fractures are actually a very diagnostic sign related down to secondary fractures related to osteoporosis. So that is what you should remember here. Simple. Last things, very simple. Fractures heal, any kind of inflammation heal, and you have to make sure that what are the factors that actually try to affect the fracture healing. The most important factors that affect the fracture healing is the age of the patient, the fracture site, which is dependent directly on the ossification centers, and then the position of the fracture fragments, because they determine the angulation and the displacement, and the degree of immobilization. Yes, degree of immobilization is actually happening because of the counteractive, the contractions caused by the adductors and the abductors. Okay, remember, it is not caused by the flexors or the extensor. It is actually happening because mostly because of the adductors and the abductors. Okay, and then last one, not the least, the blood supply is the site at the site of the fracture is also the one that actually determines how the fracture is going to get healed. For example, to say, if the age of the patient is old enough, the fracture may take a long time to heal because of the calcium content and calcium metabolism. The fracture site, let us say if it is happening down in the long bones, bigger bones, it may take a long time to heal. For example, to say tibial shaft fractures, humeral shaft fractures, or the femoral shaft fractures. Then the position of the fractures, if there is a displacement of the angle, if there is an oblique fracture, if there is an oblique fracture and the displacement is there, yes, it will take a long time unless the fracture is not going to be positioned back into correct normal anatomical orientation. Okay, that will take a long time. Degree of immobilization. Okay, if the if the fractured site is actually frequently moved, it will be under frequent stress, it will be under frequent torsion, so there will be less healing. Blood supply. Okay, if let us say if the nutrient artery is not really well supplied to the area of the fracture, again the healing will be delayed. So these are the main factors that actually control the uh, healing fractures. Okay, but however, immediately after the fracture there will be a hemorrhage in the fracture site, which can actually cause a control system that is called as the compartment syndrome. Okay, I think I told you last time, if there is a fracture and there is a hemorrhage in the fracture site, it is actually called as compartment syndrome. Okay, and you see here, uh, just wait. And then here the callus bone actually starts to heal first. Okay, the first one, how the fracture healing may happen. Okay, the fracture line actually minimally widen at this time for the first few weeks because of the activation of the osteoclast. Osteoclast actually the one that actually remove the bones that are being destroyed, right? So destructive cells are the one that are being completely removed. Bone resorption is going to happen, and that will be done by the osteoclast. So that's the reason at some point of time during the first several weeks, the fracture line may actually widen. But later, over the course of time, new bone formation will be coming to bridge the gap along the fracture, and that will be done by the chondrocytes, right? Osteocytes. So now you see here factors that affect fracture healing. Okay, so these are the things that you should be remembering down. Okay, I have already explained youth actually generally have more fracture healing, old age generally delays fracture, early immobilization without movement, okay, it causes complete rest actually causes good fracture healing, delayed immobilization causes complete stress, again repeated stress, and it causes delayed healing. And then adequate duration, okay, less time of immobilization, less healing, more time of immobilization, more healing, good supply, good healing, good passage of nutrients, poor blood supply, no passage of nutrients, and poor healing. Physical activity is completely present, but on delayed fracture healing generally the patient's steroids like dexamethasone is associated with causing secondary fractures. Remember, corticosteroids are the one that actually causes osteoporosis, calcium metabolism problems will be seen, and the best famous drug is dexamethasone for it. Okay, remember that one. Dexamethasone actually causes, okay, dexamethasone actually causes osteoporosis. Then adequate mineralization, okay, phosphate and calcium are necessary along with vitamin D3 as well, but in conditions like osteoporosis and osteomalacia they don't heal fast. Okay, and internal endosteal healing is actually causing the indistinctness of the fracture line where there will be obliteration of the fracture line, which means to say internal endosteal healing eventually causes obliteration of the fracture line, whereas external periosteal healing actually is calling the bridging of the fracture site. So you have to remember there are two types. One is the widening of the fracture line, and other is the bridging of the fracture line. So that is what it is important here. So now you see here there are there is a fracture line that is present along the proximal end of the let us say surgical neck of the radius, left radius here. Okay, and then there is indistinctiveness that is present down here. So this one actually indicates that there is the internal endosteal healing has started here. But you see here along the white arrows there is a lot of hypercalcification or the hyperdensities that are seen along the cortex. So this actually indicates that the fracture that has been actually present here did not heal but has been started to heal from the outside. So that is actually called as the malunion fracture. So that is, see, did you understand this point? It is quite simple to understand. Okay, this is one of the complications of the fracture. Fracture started to heal from the outer cortex, but the fracture line that is present down, this one has been healed by the endosteal healing. So that's the reason this is still persistent down as the hyperlucent area, but still this became hyperostostic or the hyperdensity along the outer regions of the cortex. Here the fraction has been healed, but it did not heal completely, and you see here there is a lot of angulation problem. So this is actually called as the malunion or the non-union fracture. Okay, so one of the complications, right? Then remodeling generally begins at 8 to 12 weeks. Okay, post fracture, 8 to 12 weeks. Okay, that is the time you have to remember. And in adults it occurs for taking down for over years of time. Anybody who has a fracture in adults generally they get healed over the years, but in children this occurs more rapidly Generally they will occur within the days 30 days or so. Okay, so remodeling is the last step of the fracture healing, okay, which will take about 8 to 12 weeks. But if it is not happening, the remodeling is not happening, you have to consider down the endocrine disorders or the metabolism that is related down to the ossifications. Okay, right? So when such kind of healing completely do not occur, we have certain complications related down to the healing process of the fracture. So such kinds of problems are delayed union, where it does not take 6 to 8 weeks of healing time is expected, and that is not happening between them. That time it is actually called as a delayed union. And however, delayed union will generally progress down into complete healing with further immobilization. Let us say a person's fracture is not healing within 6 to 8 weeks, then generally you actually stay and put the person in the cast for more time and suggest more immobilization so as to promote healing. Okay, but if it is not happening, that is actually called as a delayed union. Okay, is this understood? Quite simple. You have to remember the terms. Okay, what are the factors that affect fracture healing? That is a very important part. And then what are the complications of a fracture? That is a very important part. So the final thing that you have to remember here are only two things: factors affecting fracture healing and fractures delaying fracture healing. Okay, complications of fractures, that is what you have to remember. Then malunion is the one that is actually mechanically and cosmetically unaccepted position, when there is the fractures completely got healed and got settled down in a unacceptable position, causing the limb deformity, is actually called as the malunion. Okay, the pictures are there, and you see here this is a non-union of the clavicle fracture. Okay, so this one is non-healed yet, and you see here it has been also present down, and but however it has formed a joint which is actually called as pseudo arthrosis. Something like they started to form a synovial joint along the clavicle. Generally there is no synovial joint along the lateral one third of the clavicle, right? But still the fracture occurred and there it formed to form a synovial lining. So a joint that is formed within the fracture is actually called as a pseudoarthrosis. Remember that term. That's it. Very, very simple. How it is recognized? It is recognized as an active fracture line that is present along with a synovial soft tissue swelling or the lining that is present along the fracture area. That is what your pseudoarthrosis is. That's what you have to remember. Pseudoarthrosis can be formed. And non-union, sometimes the fractures do not heal at all. Okay, they do not occur at all, but still they will form a smooth and sclerotic margins and distraction of the fracture fragments. So that one is actually called as a non-union. The pictures are present in your practical slides. You can see it. Okay, the well detailed things are given down again in the practical slides. Read this chapter completely. Okay, all the examples. Okay, all the pictures, try to learn them. Okay, they are very, very important. All the fractures of the, you know all the fractures related down to the arm and forearm are very important. Supracondylar fracture, Cooley's fracture, Smith's fracture, Zone's fractures, okay, are very, very important. And again the femoral head shaft fractures are very important. Avascular necrosis is important. Types of fractures according to the direction line. Okay, and then Salter-Harris classification, Gustillo-Anderson classification are the most important things that you should remember in these whole chapters. Did you get it? Did you hear? Types of the fractures according to the direction line. Types of fractures according to the atmosphere. Gustillo-Anderson's classification. Then Salter-Harris's classification of the epiphyseal plate and their types. Okay, and then the fractures of the upper limb and the lower limb and their mechanism of injuries. Cooley's fracture, Smith's fracture, Jones fracture, supracondylar fracture. Okay, all of them are to be learned very, very for sure. Okay, very, very important. Okay, and then process of the fracture healing and complications of the healing, and then factors that affecting fracture healing are the important parts in this chapter. Without this, you will not be able to understand orthopedics at all. So for your knowledge purpose, I have made your PowerPoint very extensive. Okay, all the points from the orthopedics chapters also are covered down here. So if you read this part of musculoskeletal system in radiology, your orthopedics is going to be very, very easy. Okay, so I think that's it. We are done. Read this chapter. If you do not understand anything in the practical slides, message me and I will try to cover your doubts.